Resectability of non-resectable liver metastases, LM, is a key objective in modern oncological care, as resection offers the only potential for cure or long-term survival in patients with metastatic liver disease. The primary focus is on strategies to reduce tumor size or improve the functional capacity of the liver, thereby allowing for safe surgical intervention. These strategies are multidisciplinary, involving advanced surgical techniques, systemic therapies, interventional radiology, and novel adjunctive treatments. Below is a detailed discussion of these measures. Sure. 1. Neoadjuvant systemic therapy. Neoadjuvant systemic therapy aims to shrink tumors and convert unresectable metastases into resectable ones. Chemotherapy. Regimens such as FOLFIRI, 5-fluorouracil, leucovorin, and irinotecan, and FOLFOX, 5-fluorouracil, leucovorin, and oxaliplatin are commonly used. Addition of targeted therapies like bevacizumab, anti-VEGF, or cetuximab, anti-EGFR, enhances response rates in patients with KRAS wild-type colorectal cancer. Immunotherapy. In cancers like melanoma or microsatellite instability high MSIH tumors, immune checkpoint inhibitors, e.g. pembrolizumab, nivolumab, can induce significant tumor regression. Locoregional therapies. These techniques are often used as adjuncts to systemic therapy or as bridging treatments. Portal vein embolization, PVE, performed to induce hypertrophy of the future liver remnant FLR in cases where the remaining liver volume post-resection would be insufficient, ensures that adequate liver function is maintained postoperatively. Ablative therapies. Radiofrequency ablation, RFA, or microwave ablation, MWA, can destroy smaller lesions, reducing tumor burden and facilitating surgery. Often used for patients with limited or oligometastatic disease. Selective internal radiation therapy, SIRT, involves the use of yttrium-90 loaded microspheres to deliver localized high-dose radiation, potentially shrinking large tumors. Transarterial chemoembolization, TACE, combines localized chemotherapy with embolization to block blood supply to the tumor. 3. Two-stage hepatectomy, TSH. This surgical approach is utilized when the metastases cannot be resected in a single procedure due to extensive liver involvement. Step 1. Resection of easily accessible metastases and induction of FLR hypertrophy using PVE or ALPPS, associating liver partition and portal vein ligation for staged hepatectomy. Step 2. Completion of resection after sufficient FLR growth. 4. Advanced surgical techniques. Parenchymal sparing surgery focuses on removing only the metastatic lesions while preserving as much healthy liver tissue as possible. Laparoscopic or robotic surgery, minimally invasive approaches reduce surgical trauma and improve recovery times. 5. Biologic and molecular approaches. Molecular profiling and targeted therapy, identifying actionable mutations, e.g., KRAS, BRAF, HER2, and NTRK, allows for precision therapy, improving response rates and reducing tumor burden. Hepatic arterial infusion chemotherapy, HAIC, delivers high concentrations of chemotherapy directly to the liver, minimizing systemic toxicity and enhancing local tumor control. 6. Liver transplantation. While rarely employed, liver transplantation is considered for select patients with unresectable colorectal liver metastases, CRLM, who meet specific criteria, e.g., no extrahepatic disease and stable disease under systemic therapy. 7. Optimizing patient selection and timing. Multidisciplinary tumor boards, close collaboration between surgeons, medical oncologists, and radiologists ensures optimal treatment sequencing. Preoperative imaging and functional assessment. High-quality imaging, CT, MRI, or PET-CT, identifies candidates who might benefit from conversion therapy. Liver function tests and volumetric analysis help assess resectability and guide surgical planning. Emerging therapies. Hyperthermic intraperitoneal chemotherapy, HIPES, may be considered for patients with concurrent peritoneal disease. Oncolytic viruses and gene therapy, investigational approaches using modified viruses to selectively target cancer cells. Liver regeneration techniques. Stem cell-based therapies and growth factors are being explored to enhance liver regeneration. Challenges and considerations. Risk of post-hepatectomy liver failure, PHLF, necessitates careful patient selection and preoperative optimization. Monitoring treatment response with imaging and biomarkers, e.g., carcinoembryonic antigen CEA, is critical to determine the appropriateness of surgery. Long-term surveillance post-resection is essential, as recurrence rates can be high. Improving resectability for non-resectable liver metastases requires a carefully coordinated, individualized approach, leveraging the latest advancements in oncological, surgical, and interventional radiology care.